Okay, good evening, everybody. Welcome to our special webinar for tonight. My name is Msaad Hussein. I'm an advanced heart failure transplant cardiologist at Prince Sultan Cardiac Center. It's my honor and pleasure to moderate this webinar for today, and thank you for joining us. This is a webinar that's organized by the Saudi Heart Failure Group in association with the Saudi Heart Association, and it is sponsored by AstraZeneca. We have two outstanding speakers for tonight. We have Dr. Ibrahim Jalidan and Professor Mark Petrie, and they will all both share with us some interesting data and studies and tips and tricks about managing heart failure. We're going to divide our session tonight into three sections. So we'll start with Dr. Ibrahim, then Professor Mark Petrie, and then we'll spend around 25 minutes taking some questions and answers and discussing what's presented. And if anybody has any questions or comments, then please go ahead and send it us in the chat, and we'll be happy to answer it. So without delay, we're going to start with the first presentation. It would be my great pleasure to present Dr. Ibrahim. He's an advanced heart failure and transplant cardiologist and an echocardiographer at the National Guard Hospital in Jeddah. He did his residency and fellowship in Canada, and then he did an echo fellowship and advanced heart failure fellowship in the University of Ottawa. He's the president of the Saudi Heart Failure Group, and he will start talking to us about heart failure disease burden in Saudi Arabia. And Dr. Ibrahim, go ahead. The mic is yours.
Thank you very much, my dear friend Musad, and thank you, Prof. Petrie, for joining us today. It's a pleasure to have you. We will be talking today. It's a continuation of a series of webinars that we started earlier this year, arranged by the Saudi Heart Failure Working Group. The aim of those webinars is to spread the knowledge and increase the awareness of heart failure in Saudi Arabia through combination of series of lecture that we did online, and also we did on site in different cities. And today we're joined by Prof. Petrie in emphasizing the role of one of the not so much new medication, the SGLT2 inhibitor in heart failure medication, in heart failure management, not just only heart failure, but as Prof. Petrie will mention, it's going to be heart failure and more to help your patient. And in order to prepare for the talk, I'm going to talk briefly about the heart failure burden in Saudi Arabia. So I'm not going to be discussing a lot the global burden. I'm going to mention it briefly. I'm going to focus more on the data that we have from the registries in Saudi Arabia and the Gulf region. I know they are a little bit limited and maybe need to be updated again and again because of the importance, but we do have some data and I will shed light on that because our patients are different, our comorbidities are different. Then I'm going to discuss about the gap of management in our communities. Briefly, I'm going to discuss the management in a couple of slides, the updates in HFrEF and MREF and HFpEF, and I will set the stage for Prof. Petrie to go ahead with explaining more why SGLT2 inhibitor is such an important medication with more insight into the trial that led to their introduction into the guidelines. So this slide is probably you saw it multiple times before. Heart failure is a global epidemic. More than 64 million people live with heart failure worldwide, and the numbers keep rising. If you look at the incidence in high income nation, you're talking about 1 to 2% of the population. We don't have an exact number in Saudi Arabia, but if we took our current population of Saudi Arabia according to the latest census, we're talking about probably 5 to 600,000 patients living with heart failure in Saudi Arabia, which is a huge number. We do have a rising prevalence in the Middle East and the MENA region, and also we do have very high burden of metabolic disease, and as I'm going to explain in the next slides. So it's one of the most common and the fastest growing cardiovascular condition. And it's driven recently by aging population, people now surviving MI, not like 30 years ago or 25 years ago when we didn't have a lot of intervention. People living longer right now with high burden of comorbid disease like diabetes, hypertension, and obesity in our community, and that will lead to increase the number more and more in the future. It's also a deadly disease, so it's not just there. It is bad for people who had it. Unfortunately, we're talking about 50, the usual number that we usually quote over the years, and hopefully now with the recent introduction of medical therapy is going to be lower, which is the 50% survival, a 5-year survival in chronic heart failure patient, which is worse than a lot of cancers that people usually afraid and dedicated a lot of resource to. And especially this increase when the patients are acutely sick and in the hospital. So they are very vulnerable after an admission, and usually they have a high mortality in the first year after admission. That's why we're going to emphasize on the role of starting therapy early for those patients. It's also costly for the healthcare system. If you look at multiple registries in the state, 1 in 4 patients usually get admitted again in the first month post-discharge due to a lot of reasons. And if you look at the HFpEF and MREF data, I was looking at multiple registries over 5 years duration, almost all the patient going to be admitted to the hospital one time because of heart failure. So it's going to drive, so it's driving the cost of healthcare system so much and giving us a lot of challenge to manage those patients. But our patient is not the same as Western population. Our local registries are like the Registry in Saudi and the Gulf Care, which is Saudi is part of it, describe a distinct phenotype of our patient. Our patient are younger, more diabetic, and more ischemic. I'm going to mention that more in details in the next few slides. And also I'm going to mention some data about our heart failure clinic in the region, and the compliance to the medical therapy. So if you look at the Gulf data and the Saudi data, they're almost similar. So the mean age in the Hearts Saudi data is 61, and in the Gulf Care actually it's younger at 59. And both registers including patient in the outpatient setting and also in the acute setting. So we do have a very young outpatient heart failure population. Also, when you look at the outpatient, when you look at a couple of studies only at outpatient in multiple clinics in the Western region, the mean age is 56, so it's even younger. So our patients usually present younger compared to the mean age that we find usually near 70s or later 60s in the European and Western registries. So our patients are having to carry this disease at a younger age when they are still productive, working age. It will carry a lot of comorbidities and great disturbance of their livelihood, a lot of cost, and also will cost the healthcare system and the whole community a great deal of burden. And that's why we really care about the management of heart failure. Also, if you look at the comorbidities, we do know that our population have a high disease burden of comorbid condition. So if you look at the hearts registry, so it's the Saudi one, 64 of almost 2/3 of the heart failure patient have diabetes and hypertension. So they do have significant comorbid conditions. Almost more than half of them have coronary artery disease. And the unique thing about our registries, which is I think is due probably to under recognition of those patients, is we do have a lot of HFrEF patients. So most of our patients are HFrEF. I don't know, is it because of the high burden of coronary artery disease, or because in our registers we don't catch the HFpEF or MREF population, because usually they are tend to be ignored and just labeled as normal ejection fraction and echo, and they're not taken care of like the heart failure with reduced ejection fraction. We do have in some of the registers high burden, higher than the 50% of iron deficiency anemia, for example, high burden of CKD, which is make our life difficult. Anybody who's managing heart failure in our community know that about the CKD, high burden of other disease like atrial fibrillation. So this will also cause a lot of problems. Our patients are, this is the Gulf registry, around 5,000 patients. We do have high number of readmissions. Acute coronary syndrome are the driver of the admission, the readmission in our hospitals. Diet and medication non-adherence, it's almost 20%. So almost 1 in 5 patients come to the hospital because of diet and medication non-adherence. Also infection and one of the drivers. So we do have a lot of sicker population, as I mentioned. If we look at the medication compliance, so I just put it next to each other to see the difference. So if you look at the hearts, which is basically the one in the left side, so this is an older database, so it's 2017, 18, so we don't have a lot of ARNI at that time. We don't have actually ARNI was not included at that time in Saudi yet. So beta blocker uptake was high, ACE inhibitor and ARB in high, but you can see that the MRA is very low, although it was one of the founding medication at that time. We did not have a number above the ARNI and the SGLT2 inhibitor in that registry. But if you look at multiple heart failure clinic, and that's emphasized the importance of having a heart failure clinic. Those are two data from Jeddah, one from that specialist, King Faisal Specialist Hospital, one from my hospital, National Guard Hospital, that recently published both of them. We can see there is a high uptake of beta blocker, ARNI, and overall RAS inhibition. It's almost 88%, MRAs, and SGLT2 inhibitor. Those are promising number and emphasize the importance of having a dedicated heart failure clinic. But I'm going to compare it later on to some of the real world non-heart failure clinic data. We do have much less uptake of those medication. Also, medication compliance is a big issue. This is actually a prospective study that was done in our center, done by our colleague from the clinical pharmacy, which was a very good study. They looked at prospectively at almost 400 heart failure patients. We excluded some of the telehealth and only included people who actually came to the hospital and agreed to participate. Almost 200 patients followed for 6 months. And we had a detailed analysis of their compliance to the medication, their health literacy, because we wanted to see why those medication first taking the medical therapy and are they taking it right? And we found that more than half of the patient having a low adherence risk score or low adherence score to the medical therapy. So although they have a higher uptake of the medication in the system, but actually there are a lot of error taking the medication by the patients. Half of them are discrepancies in the pharmacy request. I see it a lot in the clinic when the patient come with multiple bags with a lot of medication, increasing unfortunately more with increasing health literacy, and that will actually lead to higher rate of hospitalization compared to the patient with that's adherent to their medication. So we do have a good number in our heart failure clinic in terms of medication prescription, but the actually taking the medication and complying to them and adhering to them is a very big challenge. If you look at the newer therapy, so at the MRAs and the SGLT2 inhibitor, our clinic data, and it's similar to the other clinics that I see in heart failure clinic, uptake is around 93%. But when you look at this real world practice, it was a systemic review that was done last year. Look at 100, almost 1,000 patient, multiple sites. It was also a pharmacy-led, a clinical pharmacy-led study, and found only 58% uptake in the population of heart failure to SGLT2 inhibitor. So there's like a big drop, although those medication are really important, as Prof. Petri is going to mention. And actually, the patients who are really not taking the medication, who are needed to take it. So HFpEF is the lowest intake of this medication. I don't know why. And also patient with lower GFR, and maybe that is expected because a lot of physicians are afraid of prescribing those medication with lower GFR, although they are beneficial for CKD and heart failure as well. So there is a big room of improvement. One of the most important thing is having a structured heart failure clinic, because that will increase the uptake, as I mentioned. It will increase the utilization of the four pillars of medication. Completing the four pillar and rapid and early GDMT titration is very important based on a lot of the trial, especially the STRONG-HF trial. And that's now why the guideline emphasizes the 6 weeks early introduction of the medication or the GDMT. Adherence is very important, as we see from our data, that even patient prescribed the medication, you need to educate them, you need to involve multidisciplinary team like clinical pharmacists, nurses, dietitian, people from other specialties like the diabetic educator to help with those patients. And we need to always track the data, and we need to update our data for sure. We need to reintroduce the registries again nationwide so we know exactly what's happening with our population. Briefly about the management, and then I will leave the floor for Prof. Petri. So I'm not going to delve deep into it. I think we've discussed it multiple times before, but for you, if you're not familiar with it, usually we divide heart failure based on the phenotype, based on the ejection fraction into three phenotypes: the reduced ejection fraction less than 40, the preserved more than 50, and the people in between are the mild reduced ejection fraction. And why we're doing this is because the management line is different. You can argue that some people argue in the heart failure world that actually medication work across them, and that's true to an extent. But if you want to go with the explicit recommendation in the guideline, you have to differentiate a little bit between the phenotype, because now we have a lot of newer therapy in the HFpEF population. So in the Saudi guideline, which speak the same language as the European and the American guideline, we emphasize on the four pillars for the HFrEF population. I'm going to explain that in details. We emphasize on the role of SGLT2 inhibitor across the whole spectrum of heart failure. We emphasize on the rapid initiation and titration, although the strong HF came after our guideline was published. And also we have the same definition of ejection fraction as the universal guidelines. So science is universal. Our task is to apply it to a younger, more diabetic and cardiorenal population. So just briefly for the people to update their knowledge about the HFrEF. So the four pillars are the RASI medication. So basically the ARNI, and if it's not available, ACE inhibitor, ARB, beta blocker, the one that we know from the trial, the bisoprolol, metoprolol, succinate, and carvedilol, MRAs, and SGLT2 inhibitor. We initiate all the four either sequentially or at the same time, depending on your patient profile. But the idea is you need to titrate very quickly in the first 6 weeks of diagnosing the patient as safely as possible. Then we can refer the patient for more therapies, devices, etc., or advanced therapy later on down the road. In the HFpEF and FMREF, so basically, if you can see here, the universal line between them, the only medication that's currently proven is the SGLT2 inhibitor. So it's the only one as a class one across both phenotyped, diuretics obviously for congestion. We can consider with a lower class of evidence the RAS inhibition, beta blocker, and MRA in the mild reduced ejection fraction. In the HFpEF, for example, if you look at the European guideline, we're only suggesting diuretics managing the hypertension, the other cardiac comorbidities. We do have emerging data now from the non-steroidal MRAs, the Fine Arts trial, the GLP-1, and I know Dr. Petri, I was actually in his presentation with the STEP HFpEF program in the ASC a couple of years ago. So we do have newer therapy that's probably gonna make their way to the guidelines soon, and hopefully that will make more improvement to our patient life. So to summarize my takeaways, so heart failure is a global epidemic with cancer-like mortality. We do have the same problem in Saudi, actually maybe worse a little bit with younger population, high degree of comorbidities because of probably high degree of diabetes, obesity, and all the other comorbidities. We do have a very big gap that we can optimize by emphasizing on the heart failure clinic role, multidisciplinary clinic role, and increasing the uptake of the medication. And we know that there are now medication that work, and one of them is the SGLT2 inhibitor that hopefully, after listening to Prof. Petri today and knowing the exact evidence behind it, it will increase the uptake at your center because it's really help our population. Thank you very much.
Thank you, Ibrahim. That's really helpful. Certainly, whenever you're talking about heart failure in Saudi, it's completely different than what we see in other worlds. So it's fascinating data that you showed us. And we're going to move on to Professor Mark Petrie. So it's really an honor to hear Dr. Petrie speak. Dr. Petrie is a professor of cardiology at the University of Glasgow, and he's also a consultant cardiologist at the Glasgow Royal Infirmary and Golden Jubilee Hospital. He did extensive work. He's a clinical trialist, and he had a leadership roles in multiple trials that actually changed what we do in heart failure. So he was involved in the DAPA-HF trial, STITCH trial, REVIVE trial, the Ironman, and he authored numerous papers, I cannot even count them. He also had a significant role in developing the guidelines that we rely on and use in our daily practice, especially the ESC guideline. And he did work on the ESC position statement in diabetes and heart failure. And we are really honored to hear him today to talk about the paradigm shift in heart failure care and what role SGLT2 inhibitors, especially dapagliflozin, has in the management of heart failure in general. So, Professor Petrie, thank you so much, and the microphone is yours.
Thank you very much. Absolutely privileged to be here speaking to you all. It's an absolute delight joining the Saudi team. I am acutely aware that Saudi has extremely high quality doctors, and what I love is hearing people looking at their own populations and not just extrapolating evidence from the US. Basically, it's fantastic to have granular data. my computer's just decided to shut down. So I'm just going to talk a bit peripherally until my Microsoft kicks up again. What we have seen is a huge change in what's been happening over the years. We've obviously had big advances in heart failure care altogether. We certainly have seen advances across the HFrEF treatment landscape, really quite remarkable, with the 4 different pillars, which Dr. Mossad has already mentioned. I'm a bit embarrassed here because my computer has just decided to restart Word, so it's just about to kick off. Give me one more second. Here we go, great. That was not ideal. So basically, we have seen huge amounts of data. I think Dr. Ibrahim already mentioned that a lot of these data are not new. So the biggest entertainment tonight will certainly be when we have the discussion. So I would encourage everybody who is attending to enter discussions about what we're talking about. So those are my disclosures, which reflect, clinical trials which I've been involved in leading. We have a real plethora of clinical trial data now with SGLT2 inhibitors. Hearing how common diabetes is in your heart failure populations is nothing short of jaw-dropping. So I'm sure you use these drugs in the diabetes area, but of course we've got data in with HFrEF now and also in HFpEF. I think it's going to be fascinating at the European Society of Cardiology at the end of August, because the definitions of HFrEF and HFpEF are going to change there. Obviously, we can't speak too much about it before it happens, but this mildly reduced ejection fraction is likely to go and just have HFrEF and HFpEF. So pretty remarkable times. Basically, the first data that came out were from the cardiovascular safety trials of diabetes therapies. So I was extremely fortunate to be involved in EMPA-REG outcome. At the time, we were asked by Boehringer Ingelheim just to demonstrate that empagliflozin was safe. And this was the era where some of the diabetic drugs actually harmed people with diabetes. So we did these cardiovascular safety trials, and we were astounded to see the benefits of SGLT2 inhibitors. So of course, we then saw canagliflozin, dapagliflozin, and all the drugs that were studied in this area, artigliflozin, that were beneficial and actually prevented heart failure in people with diabetes. So absolutely remarkable. So that caused gasps and excitement and launched a whole lot of other trials. So if these drugs could prevent heart failure, then obviously, not obviously, but it was fairly clear that these drugs could treat heart failure. So we saw these series of trials being launched. So I'm going to go through each of them relatively quickly, because I'm sure a lot of you know these data already. So again, DAPA-HF was a trial which was led by our team. It was a relatively small trial, so just under 5,000 people with classical HFrEF, so ejection fractions less than or equal to 40% with slightly elevated NT-proBNPs, and they were randomized simply to DAPA-10 or placebo, so really straightforward trial. The people that were excluded were people with eGFRs less than 30 or type 1 diabetes and very low blood pressure. So these days, people ask me, when do you not give SGLT2 inhibitors? And that's probably the bigger question. And looking at your specialist heart failure clinics, 80 or 90% of people are getting these drugs. So the only people I don't give these drugs to are people with the eGFRs less than 20, reflecting the evidence base across the DAPA and EMPA trials, and type 1 diabetes. There's one other group, which is people with previous DKA. I don't give them SGLT2 inhibitors either, but perhaps we can discuss that. And the primary endpoint was a cardiovascular death or heart failure event. And you'll all be aware that we were, again, thrilled when we saw these data, but now 7 years ago, a 26% reduction in cardiovascular death or heart failure event. And importantly, a 5% absolute reduction. So we can remind ourselves that the treatment effect was large. And this feeds into the 4 pillars. You'll know we did the analysis looking at the effect of modern heart failure therapy against just ACE inhibitors and beta blockers, where we found a 50% reduction in mortality and a 70% reduction in heart failure events. So here is DAPA with a 26% reduction in cardiovascular death or heart failure event. And you'll have seen these data just about how early the treatment effect is. So so I did a ward round this morning, so lots of heart failure patients, and we don't mess around. So on day 1 now, I'm prescribing these medications. We see the treatment effect very early. The drugs are very well tolerated. There are really hardly any issues at all when you prescribe these drugs. So again, looking at the components of the primary endpoint, we were obviously hopeful to reduce the primary endpoint, but this was beyond our expectations, a 30% reduction in heart failure event, but also a reduction in cardiovascular death, which we were really pleased to see. I think when we reduce death, it really hits home to everybody, whether you're a heart failure specialist or a generalist or a primary care or anybody. I think these data were absolutely fantastic. So at the time, when we designed DAPA-HF, there was a lot of discussion about whether or not to have people without diabetes in the trial at all. People still thought these drugs had something to do with diabetes. So we got this paper out really quickly in JAMA after the publication of the main paper. So this is looking at the effect of DAPA in people with and without diabetes. And again, we were absolutely delighted to see the treatment effect was the same in people with and without diabetes. So absolutely fantastic, to see that these data were really novel at the time, and the fact that people without diabetes benefited in the same way as people with diabetes was astounding. So we did an analysis looking across the range of baseline HbA1cs. We saw exactly the same treatment effect across, regardless if HbA1c was 6 or 8 or 10, it really didn't matter. So absolute party time that we were delighted. Again, we showed that people without diabetes, there was 0 change in HbA1c despite a reduction in death and heart failure events. So we really, that paper really put to bed the notion that this was anything to do with glycemic control or glucose lowering, and just these are heart failure drugs. So again, as well as reducing the primary endpoint, cardiovascular death and heart failure event, we also saw improvement in quality of life as measured by the Kansas City Cardiomyopathy Questionnaire. This was regardless of how we looked at it, so the total symptom score, or the clinical summary score, or the overall summary score. So all of these domains that you know about, looking at health status, we saw benefits across the health status. So people felt better, which really, again, when you're managing people day to day, people want to come back to clinic feeling better, as well as be told they're less likely to be hospitalized or die. So these are really powerful data. I know, again, the deterioration, preventing deterioration is really important for clinicians to be aware, because just because somebody comes back and they feel the same doesn't mean that the drug hasn't worked, because you could have prevented deterioration. And we did see prevention of deterioration as well as frank improvement. So that was absolutely great. And the numbers needed to treat were not the sort of statin numbers of 200 or whatever. These are low numbers, less than 20. So again, EGFR dips, we all know now that these drugs do cause a transient reduction in EGFR when you start using them. We've now looked across the MRA trials, the ACE inhibitor trials, the ARB trials, the scubitril/valsartan trials. Every heart failure therapy causes an EGFR dip. We now know that. We didn't know that at the time. But while we see a small EGFR dip at the start, we see better kidney function at the end of the trial. So we slow EGFR decline with these drugs. So again, as heart failure clinicians, we know not to check too often the EGFR during starting these drugs, and whatever we do, we stop our junior doctors or pharmacists or nurses or non-specialists, reacting to small changes in creatinine or EGFR when you start these drugs. So I think all of us know that, and we spend a lot of time in our ward rounds telling people that a small change in EGFR is not acute kidney injury. It's just a hemodynamic consequence of starting these drugs. Again, the same message for doubling of serum creatinine. You're much less likely to double your serum creatinine on dapagliflozin than placebo. And again, that speaks to a lot of generalists if we hammer home that message. And again, if we look at the effect on the primary endpoint, people with EGFR dips or no EGFR dips or across baseline EGFR, we see the same benefit. So these drugs are frankly beneficial for your kidneys as well as beneficial in terms of heart failure events. So again, thinking back to when we published this, people were worried about lots of things, volume depletion, the endocrinologists were worried about that, and kidney problems and amputations and hypoglycemia. So we looked at these in really close detail, adverse events of special interest, and we didn't see any of these being a problem. What we did see were there were less serious adverse events with dapagliflozin than placebo, and really the same amount of adverse events altogether. So again, we reassured people that we were not doing all of these bad things. Maybe we can come back to the GLP-1 story, which is currently happening. I'm glad to say I'm closely involved in the trials of GLP-1 receptor agonists and heart failure as well. So maybe we can discuss that. So again, one thing we do cause, and we have to be clear about this, that SGLT2 inhibitors actually do increase the rate of genital tract infections, but that is not by a lot. If you look across the heart failure trials, it's about 1 to 2 in 100, and they're easily treatable by oral or topical therapy. And if you encourage genital hygiene, we don't see big problems. And very rarely do you have to discontinue the drug due to genital tract infections. That's about 3 in 1,000. So this does happen, genital tract infections, but it's preventable, treatable, and doesn't result in stopping these drugs. UTIs are not increased by these drugs. It's a very small increase in one of the many heart failure trials. So overall, urinary tract infections are not increased, but genital tract infections are. So that's a really common misconception. So again, here is the data from the empagliflozin trial, EMPEROR reduced, showing that there was a slight increase in genital tract infections, which can be overcome by counselling and education and not stopping the drug. I've said already that the diabetic ketoacidosis is a problem as well, but a very small problem. So again, we almost had hysteria from some people about this. Looking across all the trials, we do see very small numbers in some trials. So in DAPA-HF, we saw 3 in the DAPA group and no events in the placebo group. But the numbers are so small, we saw none in EMPEROR reduced, and actually more in placebo than in the sotagliflozin group in SOLOIST. So we do have to be vigilant, be alert. But when DKA does happen in people, diabetic patients on SGLT2 inhibitors, this is easily spottable. So it's in high-risk situations like fasting for major surgery or major sepsis or major problems with glycemic control. So it rarely happens out of the blue. It's really easy to spot and predict, but people need to be aware. Small increase in genital tract infections and a very, very small increase in DKA. But if you contrast that with the major treatment effects of death and hospitalization, improved quality of life, I think we're all comfortable now. So another major misconception is blood pressure reduction. So SGLT2 inhibitors have a very, very, very small effect on systolic blood pressure. So across DAPA-HF, we did this analysis, which shows we lower blood pressure by about 1 millimeter of mercury. A really fascinating observation is if you start with a higher blood pressure, as in above 130, you see a reduction of blood pressure by maybe 3 or 4 millimeters of mercury. But if you start with a lower blood pressure, less than 110, it's more like 1 or even half a millimeter of mercury. So again, we see people stopping SGLT2 inhibitors for hypotension. That really doesn't make much sense. And other drugs like sacubitril/valsartan certainly does reduce blood pressure, and that can be problematic. It's obviously a fantastic drug, sacubitril/valsartan, but we do recognize the blood pressure effects. So another thing which people got excited about was the diuretic effect of these drugs, and people were stopping loop diuretics all over the place. So when we looked formally at DAPA-HF as a trial, about 3% of people in the DAPA arm compared to the placebo arm had a reduction in loop diuretics. So as a team in Glasgow, we don't recommend routinely reducing loop diuretics. Very rarely you do reduce them because you have a combined effect of of MRAs and SGLT2 inhibitors and sacubitril/valsartan. Sometimes you can stop them, but really we as a general rule continue them. So again, there was excitement about maybe the treatment effect was only on people not on any other heart failure therapy or on very low doses of other heart failure therapy. So we conducted this analysis which showed the treatment effect of dapagliflozin was on top of any combination of heart failure therapies. So whether you were on top dose of everything else or the bottom dose or whatever combination you want to think of, we saw a consistent treatment effect. So as Dr. Ibrahim says already, we just start these drugs before people go home, if they're hospitalized or when we first meet them. And really, we don't mess around for the early treatment effect. Another thing people talk about is age, and you can't use these drugs in old people. That's not true. We had a lot of people who were elderly in DAPA-HF, and we saw a consistent treatment effect across baseline age. We also, as well as the treatment effect, we saw the same benefit in terms of safety as well. So the safety profile was excellent. Clearly, in clinical trials, we don't see the extreme frail patients, the extremely old people with lots of comorbidity, but certainly in people where you think this is reasonable to use, we saw an effective and safe treatment effect. So again, ejection fraction-wise, within DAPA-HF, we saw a consistent treatment effect across baseline ejection fraction, whether you were 20, 30, or 40. There was no issue there, and I'll come back to the other trials later on. NT-proBNP, again, it didn't matter what your NT-proBNP was, we saw the same treatment effect. So really every way we looked at the trial, we saw a consistent treatment effect. People said, well, should I use an RNA or an SGLT2 inhibitor? So we did this analysis looking at the treatment effect on an RNA or not on an RNA, and we saw the same consistent treatment effect. So these are complementary drugs working in different pathways. We use these drugs together. And really, as Dr. Ibrahim said, we in heart failure clinics, team services, we see these drugs working together to reduce cardiac events and also to improve cardiac function as well. I'm sure in your heart failure clinics, you'd have the same experience of me every week. We see people's hearts improving. So the guidelines, of course, changed, and a class 1A recommendation for all the 4 drug classes. And I'm sure that in Saudi, looking at your numbers in the heart failure services, the well-organized heart failure services, people are using these drugs in high doses. Just to say, obviously, empagliflozin was studied in EMPEROR-Reduced, very similar trial, very similar patient population with a very similar result. So really fantastic to see this drug class working well. So I'll just go over that. So just turning now to HFpEF. So I've looked at the HFrEF data. This is now the HFpEF data. So it's fascinating to hear that you see mostly HFrEF patients. I personally think that probably is what Dr. Ibrahim said about missing HFpEF, because if you look in primary care and diabetes clinics and kidney disease clinics and COPD clinics and general medicine wards, HFpEF is everywhere. It does depend how you define it, but people with elevated NT-proBNPs and ejection fractions greater than 40% are really everywhere. Large left atrium and LVH is extremely common. So my prediction is that people will start recognizing this. We've just finished a trial screening for HFpEF in diabetes clinics, and we found that 1 in 4 people in diabetes clinics, depending how you define HFpEF, have HFpEF. So there is an avalanche of HFpEF coming all of our directions very soon. So this again was the first positive trial of an evidence-based therapy in HFpEF with empagliflozin, so EMPEROR preserved. So almost 6,000 people with very clearly recognized HFpEF, so elevated NT-proBNPs, echocardiographic abnormalities, and NYHA class 2 to 4. Again, no type 1 diabetes, eGFR is less than 20 here, and the same primary endpoint of cardiovascular death and heart failure hospitalization. So again, great. People recognize conditions when they've got good treatment. So here we see the first positive HFpEF trial, 21% reduction in cardiovascular death or heart failure hospitalization. So closely following that, the dapagliflozin trial, again in HFpEF, very similar trial. The major difference here was including people with improved ejection fraction and also hospitalized people, because the EMPEROR preserved only had ambulatory patients, not hospitalized. So again, you'll see lots of people in Europe and Saudi Arabia, almost 50% of the population, 20%, almost 20% with improved ejection fraction, and there were around 650 people who were hospitalized. So really good data and well treated. So MRAs in over 40% of people. So we were delighted to see a well treated population having a positive trial. So again, 18% reduction in cardiovascular death or worsening heart failure event. It's important to say that in both the dapagliflozin trial, DELIVER, and EMPEROR Preserved with empagliflozin, we saw the treatment effect was driven by a reduction in worsening heart failure event, but there was a reduction in cardiovascular death of 12%, but that was not statistically significant. So again, there was a lot of excitement about in DELIVER whether we saw treatment benefits across the different ejection fractions. So over 60% or less than 60%. And again, we saw that we did see a treatment effect across the different levels of ejection fraction. There was some doubt about that after EMPEROR Preserve. I think this trial analysis put this to bed. So benefit across the ejection fraction of HFpEF. So again, that's a clear analysis about the ejection fraction in HFpEF. These are the data, 650 people who were enrolled during hospitalization. So again, safe and effective in HFpEF, really great to see. And again, an improved ejection fraction. Again, we saw this treatment effect the same as people who had HFpEF that was long-standing. So again, this just broadens the indications. Again, the primary endpoint was time to first event. This was second endpoint was a total heart failure event, so counting all the heart failure events. You see lots of people had lots more than just the first event, which is very important to think about in HFpEF. So you're reducing the total events, not just the first events. And with the treatment effect there, you can see was 23%, so really satisfying. And again, improvements in KCCQ, people feeling better, health status better, which is again important for patients. The same message here about adverse events. People were worried about all these things like DKA and amputation. And again, we saw the same message. Genital tract infections increased, a really small number of DKAs, but nothing else to worry about. Volume depletion, hypoglycemia, anything like that, not a problem. So we then moved on to a meta-analysis of DELIVER and EMPEROR Preserved, and we saw across DAPA and EMPA in HFpEF, we saw a 20% reduction in cardiovascular death or heart failure event. Very frustrating finding for cardiovascular death, so 12% relative risk reduction and a p-value of 0.052 to just miss significance. Again, this thing about ejection fraction, people were concerned about EMPEROR Preserved and maybe not a treatment effect in the higher ejection fractions. If we combine the data from DELIVER and EMPEROR Preserved, we see a consistent treatment effect across ejection fraction. So for the next few slides, I'm just going to show you some data that we did on a meta-analysis of DAPA-HF, the REF trial with DELIVER, the PEF trial. So that was up to 11,000 patients with good follow-up, 22 months follow-up across ejection fractions. So here we look at cross ejection fractions. Cardiovascular death was significant, so a 14% relative risk reduction. That was cardiovascular death. This is all-cause death, a 10% reduction. Again, combining all the data, there was a statistically significant benefit. Again, total hospitalizations, so not just the first, but all of them, 29% across DAPA-HF and DELIVER. First hospitalizations, 26%. If we look at the broader MACE endpoint here, so cardiovascular death, MI, and stroke, a 10% reduction. Again, in heart failure trials, we don't see too many MIs and strokes, so that was good to see. And again, these are data just looking at the x-axis here is across the spectrum of ejection fraction. Again, you can see cardiovascular death very clearly reduced across ejection fraction, all-cause death, same analysis. And again, this is heart failure hospitalizations, both first event and total events, and the primary endpoint, cardiovascular death or heart failure hospitalization. So again, the hospitalized data was strong in DELIVER, but this is a dedicated trial, EMPULSE, with empagliflozin of 530 patients with heart failure across ejection fraction, looking at the efficacy and safety of SGLT2 inhibitors in hospitalized patients. And you'll know the data showed, looking at a primary endpoint, a win ratio of death, heart failure events, and cases EQ. We saw that that the SGLT2 inhibitors had a positive treatment effect and were safe there. So I'm not going to talk about all the CKD trials, but again, you know we've seen lots of positive CKD trials, and obviously your burden of CKD is huge in Saudi Arabia. So lots of positive trials here. But just because we're talking about cardiology and heart failure here, I wanted to select just the DAPA dapagliflozin data from DAPA CKD. So when you start off with a CKD population and treat them with dapagliflozin to improve kidney outcomes, you actually reduce cardiovascular death or heart failure hospitalization by 29%. So obviously, people used to be scared of using these drugs in kidney disease. We've seen clear benefits in terms of kidney metrics, but also, really importantly, the cardiovascular death and heart failure in kidney populations. I'm not going to go through all the trials, but it was a consistent message across the trials. So I was really delighted to hear about heart failure teams in Saudi Arabia. And this is essential to manage people with heart failure because non-specialists do not manage heart failure well. So in Scotland and Glasgow, we have clear pathways of heart failure care. So when a primary care physician, a general practitioner, suspects heart failure, they take an NT-proBNP, and if that's elevated, they send us the patient. We do an echo, we look at the patient, we then send back the patient with the summary of their diagnosis. We do the investigations of the cause of heart failure. We image them, we counsel them, we treat them, and we get them all the therapies, and we send them back to primary care with a clear pathway back in should they struggle. The same for secondary care. If they're in the wards, we welcome them into the cardiology wards. We don't just focus on stents, we welcome them into the heart failure, into the cardiology wards, and we look after them. These people are at high risk of bad things. We've got excellent treatments. Obviously, stenting is important, but it doesn't take that much to start somebody on a dual antiplatelet therapy and a statin or whatever. So really, the heart failure care needs to be done well. It's about good diagnosis of the cause of heart failure, the presence of heart failure, device therapy, advanced heart failure care. It's really important to do this well. So we do this systematically. We've got pathways of care so nobody can escape excellent heart failure care. This is recommended by the ESC 2021 guidelines that heart failure must be managed by a heart failure team, class 1A recommendations. And this is not just people saying it because they're crazy fanatics. This is evidence-based. So we've done some of these trials. We've shown MDT, multidisciplinary heart failure teams, so with nurses, pharmacists, doctors. I'll come back to exactly who these people are later. But we see clear improvements in mortality and hospitalization. So please organize your cardiology teams into people that care about heart failure and want to manage heart failure well. This is historical. Cardiologists working alone is not a heart failure team. You can't look after heart failure in isolation. If you're doing this, that's the wrong thing to do. So core heart failure team is heart failure nurses working across primary and secondary care, cardiologists of all shapes and sizes, so heart failure cardiologists working closely with imaging cardiologists and EP cardiologists and device implanters, advanced heart failure people. So this is a teamwork. Heart failure pharmacists are brilliant as well. Again, it's great to hear they're doing good research in Saudi Arabia as well. Our heart failure pharmacists are passionate and fantastic, really, really important. Also palliative care. So in my heart failure team, heart failure service, we run every day. We have palliative care, recognizing end of life or terminal care, as well as supportive care. Somebody's dying, they're dying. We need to do that well as well. So again, this is the old hospital that I work in, Glasgow Royal Infirmary. This is what we have, and this is a daily, lots of people. There's not one or two people. We have lots of heart failure cardiologists, nurses, really looking after people enthusiastically and being rewarded. So heart failure management should be organized, systematic, and not random. And I am delighted to hear that's happening and going well in Saudi. So summary, I think, is very, very clear. Across the last 7 years, we've seen huge accumulation of data for SGLT2 inhibitors across diabetes, across the heart failure ejection fraction spectrum and kidney disease. We've got great evidence for DAPA. I'm very happy, though, if we discuss other things in the discussion. There's lots of other things happening in heart failure, which I'm sure that those of you who are spending your evening with us want to talk about, and I'm sure Dr. Ibrahim and Dr. Mossad also want to talk about some other exciting things. Dapagliflozin is super exciting, but there are other exciting things as well. Thank you very much for your attention and time.
Thank you, Professor Petrie. That's a really great presentation. You clearly showed like why this class of medication is important, and at the end, you showed greatly why we need heart failure teams because caring for heart failure patients is certainly not straightforward. So, encourage everybody to, if they have any questions, to type their questions in the Q&A, and we'll try to answer most of them. And in the meanwhile, I'm going to start with just a few questions to Prof. Petrie and Dr. Ibrahim. Prof, a lot of people like you did a lot of clinical trials, and when I speak to people like about, let's say, SGLT2 inhibitor, and like how the DABA-HF showed a reduction in mortality, and then when Deliver came out and Emperor preserved, there's no reduction in mortality, and people get disappointed. Like, okay, there's improvement in outcomes, but there's no reduction in mortality. So people are often asking, like, why is that? Why do you think, like, if you can explain why we did not see this profound like benefits as in HFrEF when compared to HFpEF?
Yeah, so I think that's relatively straightforward because people with HFrEF have high rates of cardiovascular mortality. Most of the deaths are in HFrEF or cardiovascular, so sudden deaths, pump failure deaths. When the further you go into HFpEF, there's lots of different causes of death, and you and I, if we look after HFpEF patients, they've got lots of things wrong with them. They die of lots of different things. So the proportion of people dying of cardiovascular death are much lower. These trials, like Emperor, Preserved, and Deliver, were not designed to show a reduction in cardiovascular death. If you did a formal sample size calculation and a power calculation to show a reduction in cardiovascular death, these trials would be much bigger. So they were not designed and set up to do that. So that's the take home, is that the trials were not designed to do that, basically. And also it reflects the patient population. I think it also reflects the different goals we have in HFpEF as well, because if you have a HFpEF patient who, again, I don't know how old the HFpEF patient is in Saudi, but in Western Europe, they can be 75, 85, and they are looking to stay out of hospital to feel better. And probably the goals, when you look at them, you're not thinking, I'm trying to reduce mortality here. You're thinking, I'm trying to make them better and keep them out of hospital. And that's the goal. So I'm not distraught about not reducing death in HFpEF. We've discussed it a lot in some of the newer trials, and some of the newer therapies, maybe the GLP-1s in HFpEF, may be well positioned because they have such dramatic, potential treatment effects. But we don't know anything about mortality with them because in STEP, HFpEF, and SUMMIT combined, there's less than 25 deaths. So we know nothing about their effect on mortality yet. But there are big, large, ongoing outcome trials now, which will have a lot of deaths. So I'm a little not confident, but I'm suspicious that we might see some fireworks going off in a few years. And in two years' time, we'll finish those trials, 2028. So we may see treatment effects there because GLP-1s do a lot. But let's see. Maybe I'm wrong, or maybe we can speak again in 2028 and we can review the results of those trials.
I can't wait for the results. Dr. Ibrahim, just like in Saudi, people have different practice. So it seems that you guys, like at least in your setup, you have a clinical pharmacist. Like most of us, unfortunately, we don't have the luxury. So at least in some centers, what do you advise people to do? Like, is it something essential that we should have, like these nurses and clinical pharmacists, or do you think it's enough to just have a cardiologist who's dealing with heart failure patients?
Yeah, I think Prof. Petri mentioned, and actually from your practice, heart failure patients are really tough to treat and manage. So it's not a one person job. It's going to be very difficult for the doctors to follow those patients, educate them, look at the medication. Like in our hospitals, they give you like 15 minutes per slot for patient. So in 15 minutes, I cannot do like 1/5 of all those things. That's why the multidisciplinary team is very important. I know it's not implemented in most of the let's say, less size or smaller governmental hospital, but is changing. So the Ministry of Health, which is probably managing 70 to 75% of our population, are investing into including heart failure clinic in each of their hospitals. It's not there yet, but I think it's developing. We do have a big gap in the private sector also as well. I'm not in the UK, probably your private sector is not as big, but here I think we have a big private sector is growing and growing. And I don't know a single private sector have a heart failure clinic. And when I started my part-time private sector, I started to elaborate in the role of heart failure nurse practitioner, for example, and they did not have a line for that. Like they said, who's this? Like, who's this person? What's their job? Why they're coming to the clinic? You are the doctor who's going to get paid and generate income. Why there is a nurse coming to see the patient? So there is still, I see it from the other point of view. I see there's a big room for improvement. Like we can improve a lot by just doing small initiations. So by having those team working in different perspective, clinical pharmacists are really important. They are the backbone of our practice in our hospital. How many times they email me, they call me after rounds, after clinics to adjust the doses, to help with the managing the medications, to pick up a lot of the mistakes that happen during grounds. So they're really crucial. And you can see from the data that they did actually, the clinical pharmacist did this study with adherence in our center. 50% is having a low or medium score adherence, which is like huge. And so I'm happy by prescribing the medication. So it's not just we need to look at it. It's not just a number that would show in the system that we prescribe 90% and 80%. Are those patients actually taking those medication rightfully? So you cannot do this by having only heart failure cardiologists. It's really important to have multiple team. And actually, we did publish recently a paper from the Saudi Heart Failure Group with the Saudi Heart Association, a position statement about how to initiate a heart failure clinic and a guidance for our local population. So hopefully that will increase the volume of heart failure clinic and pick up the volume of that. And
Thank you, Ibrahim. Professor Petri, one question I keep getting a lot, and we got here, and maybe you should help since like you designed the trials of SGLT2 inhibitors. Like a lot of people really worry about UTIs. Like you wouldn't believe how many like patients they have HFrEF and they or HFpEF and then they get a UTI and then the physician or like the healthcare practitioner just stop the medication. So what is your advice? Like if like what is your simple advice to people on the issue of UTIs and SGLT2 inhibitors? Do you stop like how many episodes they need to get before you stop it, or what's your threshold to stopping it? Because this issue confuses a lot of people. So do you have something practical for people to they can use or an advice?
Yeah. So thank you for that, Dr. Mossad. So basically, again, when I went into cardiology, I never thought I'd be discussing UTIs or genital tract infections. It's a complete surprise to me. And I think that partly reflects why we get confused about it, because most people dealing with this have never thought about what a UTI is and what a genital tract infection is. And people say GTI as though every cardiologist knows what you mean. So basically, we need to separate genital tract infections from urinary tract infections. So genital tract infections are increased, and that's thrush, just to be clear, because again, some people don't know what you're talking about. So thrush around your genitals. So that's not great to talk about, but that's what we're talking about. So obviously women are used to getting thrush because it's quite a common thing. And men are not so used to getting it. So it's more common in women than men. So basically what we do, and we are lucky because we do have pharmacists and nurses, we do a lot of this education, and they're prescribers as well. So just be clear. So they do their own patient list, they prescribe. So anyway, what we do with the patient is we do verbalize it. So before we start these drugs, we say these drugs can increase genital tract infections. So we say, genital hygiene is important. So we verbalize that. So you need to keep your genitals clean, which again, I never thought I would be saying, but I'm saying that. And then you say, if it does happen, please tell us it's happening. Tell your primary care physician, because they are used to treating thrush, basically. So they treat thrush, and we say, do not stop the drug, because we say it only happens when you first start taking it, because you get more glucose in your urine, and the bugs like where there's more glucose. So we say treat And basically, I say, do not let your GP stop your drugs when it first happens, or when the second time happens. I say the third time, okay, fair enough. If you get 3 GTIs, then you stop. But obviously, you need to speak to the patient about that. You say, are you willing to carry on again? But these drugs will explain the benefits. So roughly 3 times is the answer to your question. Urinary tract infections are totally different. So that's your bladder and your ureter, obviously. And bladder infections in the trials are not increased, apart from one trial. Emperor Preserved showed a very slight increase in urinary tract infections. So generally, I don't stop them for UTIs, because UTIs are not increased. Occasionally, clinically, I see somebody who has had recurrent UTIs on these drugs. I can't be certain there's not ever an effect with a trial scenario. So if somebody's having problematic, complicated UTIs which are recurrent, yes, okay, I stop, but not for every UTI. UTIs are super common, particularly in people with diabetes. So I don't stop them, and that is really an issue. So GTIs, yes, it does happen. Don't stop the drug. Talk to the patient about it. If you manage to keep them going, it doesn't come back. UTIs really is not an issue that we know of, but in reality, if somebody's got a big problem, I think it's okay to stop them.
And I think this is really, really important. I wish like we can just write the sentences you said like in a piece of paper and just give it to people, because a lot of people feel frustrated or confused about this issue. So I think this is really helpful. Prof. Petri, another question that we got uh, now for HFpEF, like you talked about SGLT2 inhibitors, and everybody probably now is comfortable with them in SGLT2 inhibitor in HFpEF. Do you envision that we're going to have, like, you know how HFrEF is like 4 pillars? Do you envision that we're going to have, let's say, 3 pillars or maybe 3 pillars for HFpEF with non-steroidal MRAs and GLP-1 receptor agonist? Do you think the ESC will come up with this terminology, or do you think we're way off for now?
Yeah, so when SGLT2 inhibitors are on safe ground, as you say, because we've got class 1 evidence, 2 big trials, that's easy. So then we've got MRAs. Let's talk about MRAs in general. So non-steroidal MRAs are in fine arts, have shown the reduction of heart failure hospitalization. So that's in chronic ambulatory patients with a few hospitalized patients. We do, though, I want to emphasize, we are waiting for more data for MRAs in HFpEF. So there's a REDEFINE trial with finerenone in hospitalized HFpEF. So we're really quite far through that, actually. So that'll be publishing in about 2 years. So that's more data. So whenever we've got more data coming, I'm always a little bit cautious and concluding that we've answered all the questions. And a trial called Confirmation as well also is HFpEF and finerenone. And then we've got the confusing trials, which are the steroidal MRA trials, not finerenone, but steroidal, which have been published recently. The Spirit trials, which are small trials, inconclusive, not well powered, but not positive. So I think we've got safe data for SGLT2 inhibitors. We've got good data for non-steroidal MRAs in chronic ambulatory patients. GLP-1s, we are early on the journey in HFpEF. We've got data showing improvements in health status in STEP-HFpEF. I was the last author in STEP-HFpEF, so I'm a big fan for people feeling better. But in terms of reducing clinical events, we only, between Summit and the 2 STEP-HFpEF trials, we've only had 76 heart failure events and less than 30 deaths. So these ongoing trials are vitally important to quantify the benefits, and cardiologists are not used to just prescribing things to improve health status. So we need to see the results of those, but those trials are rapidly, ongoing, and we'll know the data soon. So I think we're early days. We're getting more pillars, but we still are developing the evidence base in HFpEF. So SGLT2 inhibitors, yes. Non-steroidal MRAs in fine art population, yes. But again, within 2 years, we should come back and answer the question for sure, because we're going to have more richer data. Steroidal MRAs, the trials haven't really answered the question, to be honest. I'd be actually fascinated to know your opinions, actually, and maybe we don't have time for that, but I'd love to hear your reflections on that, Dr. Morsad.
Well, I think, like as you said, like we're seeing a lot of data coming out, and honestly, like the problem with HFpEF, I found they're very difficult to deal with. So I work in I have a private clinic. I do advanced heart failure in a government hospital, so I only see a HFrEF, but I also have a private clinic, and so I'm not surprised actually. All of my patients are HFpEF. Like I'm seeing a ton of HFpEF, and they're quite frustrating to deal with. So you even like okay, we start this GLP inhibitor. I start amphetamine, although like we just got the approval last year, but still we're having events, we're having admissions. So I think we need more tools. Like I don't think
The GLP-1s are tempting to use, and I do use them in my clinic because people who are very heavy, they lose 20, 25 kilograms, they feel a hell of a lot better, they want to give you a hug. So, it is good, but we have to be clear, we're cardiologists, we're into the business of event reduction, so we should be doing large trials. I'm delighted we're doing trials. There's going to be 3 large outcome trials of HFpEF of incretin therapies. So we will have those data. It's satisfying to prescribe them because people love you and they seem to do better, but we don't have the hard data to back up our decisions yet.
uh, just we have a couple of minutes, so maybe I'll ask Dr. Ibrahim a question, then Prof. Petri the final question. Dr. Ibrahim, one question we got about urine ACR, like, do you check it routinely in your practice, like as a heart failure cardiologist? And what do you, like in your patients, do you check it routinely? And would it alter what you do with your management or no?
Yeah, excellent question, Musad. Actually, I do. I started actually checking it after the SGLT2 inhibitor data. It was not part of my routine practice usually, and I had a lot of issues also with the insurance rejecting the labs multiple time. And I started to have like my own copy paste statement, like for hypertensive patient or anything. As per the guideline, we have to check the UCR Q6 months. So I always check it and. I found it a very good excuse to start those medication in patients who are you're struggling with basically the HFpEF and you're not sure about the data still in the heart failure. So usually I use it for those indication. If I find them diabetic, I usually switch to their glycoside or their oral like other non-mortality benefit cardiac medication to the SGLT inhibitor. I use the Fendrinone because of that, and I think there is data from the Confidence trial, if I'm not mistaken, the one that showed that the combination therapy actually dropped the UCR by more than 50% compared to 30% each medication, alone with good safety profile. They don't have any significant side effect profile, except maybe for some of the hyperkalemia that we should be careful with the non-steroidal MRAs. So I do check it now more frequently. I do encourage my colleague to check it, and I do change my practice with it.
Thank you, Dr. Ibrahim. Prof. Petri, just a final question before we conclude. And I'm going to give you 2 special population, we call them. So the 2 special populations are type 1 diabetics and patients with end-stage kidney disease on dialysis. So we know the trials excluded those patients from using SGLT2 inhibitor. In your advice, I know like in the trials they were not included. What would you do for these populations, like type 1 diabetics and those who progress to end-stage kidney disease on dialysis? Is there any role for SGLT2 inhibitor, or you think at this stage we need to wait and see?
Yeah, so the type 1 diabetes for me is not a territory where I'm a specialist. So I don't give them to people with type 1 diabetes. If I feel the patient's got a terrible heart and I really want to use them, I then communicate with my endocrinology colleagues, and sometimes they do it. So I don't want to do that as a cardiologist in isolation. So I have done it. There is again, I'm like a broken record, but there is an ongoing trial in heart failure called SOPHIST, with sotagliflozin in type 1 diabetes and heart failure. So we'll have some data about safety and efficacy from there. So at the moment, I don't go there personally. The second question about end-stage kidney disease. So in the trials, so all the DAPA and EMPA trials, what happened was the drugs were started and continued regardless of what happened to people's kidney function. So that was up to dialysis, transplantation, whatever. I'm happy continuing them in people with lower EGFRs because that reflects the trial. What I don't do is initiate. I'm quite a strict trial guy. So if somebody's EGFR is less than 20, I do not initiate these therapies as a cardiologist. Again, if I feel passionately, if somebody's EGFR is 15 and I really want to use them, I then liaise with the kidney doctors, and sometimes they say, well, yeah, let's do it, and they keep a close eye on them at that point. But if you're getting close to that kind of territory, you're nearing kidney replacement therapy anyway. So I think they're probably well placed to be managed with the kidney doctors. So I don't do it, without close collaboration with the kidney doctors.
Amazing. Thank you so much. I think we're almost out of time. That was great presentations, and thank you so much, Dr. Ibrahim Jalidan, and thank you so much, Prof. Mark Petrie. Hopefully, for the audience, you guys had a good time and you enjoyed the discussion. Certainly, we have a lot of things that are coming out in the heart failure world. I remember, like, I was lucky enough to see the old ACE inhibitor beta blocker and then the transition to the newer therapies. So I'm glad that I saw the old, like, let's say the old practice. So hopefully over the next few years, we're going to see more data emerging and we're going to have more discussions about how do we care for our population. Thank you so much, Prof. Petrie. Thank you so much, Ibrahim. And thank you so much for the audience and the Saudi Heart Association. And hopefully everybody will have a good evening.
Thanks, everybody. Great to see you guys. I hope to see you in person Sunday as well. Great to see you.
Thank you so much.
Thank you very
Bye-bye.
much. So much.
Bye-bye.
Bye-bye.